Pakistan. First of all, it's my first time hooking up with you folks in Pakistan, so I want to welcome all the medical schools which are joining. I believe 3 have joined Dow University, Sheikh Zayed and King Edward, and I hope the other 4 can join too, RMC, Dow Medical Institute, Liaquat University, and Allama Iqbal. So I'm not going to go over my bio. You probably already know what I do. So the topic today is autism spectrum disorders. I'm going to give a brief overview, and then we'll have question and answers in the last 15 minutes. So just first of all, as you know, in US and probably in Pakistan nowadays too, that I don't have any disclosures. I don't get any support from pharmaceutical industry or anyone else. So just want to make that disclosure. Probably, I hope a lot of folks are from psychiatry or pediatrics. You're probably seeing children and adolescents with autism spectrum disorders or pervasive developmental disorders. When we say what are pervasive developmental disorders, there are 5 categories in DSM-4. The 3 most common are autism, Asperger's disorder, and pervasive developmental disorder not otherwise specified. Hello? Screen. 1 minute. Share the screen. I have to exit this first. Just click the participants.
Press F5, please.
Daniel, can you hear me?
Yes, I can hear you. Please press F5 so that your slides may maximize. F5. Yes. Thank you. All good. So you can proceed now. Thank you.
Can I just continue where I left?
Yes, or you can please start over because your slides weren't shared. Yeah.
Okay.
So, thank you.
Sure. Okay. So just starting again, just going to talk about autism spectrum disorder. So this is just the initial slide, and then the disclosure which I already mentioned, and then I was at this slide, which is the 3rd slide, talking about pervasive developmental disorders or autism spectrum disorders. So the 3 most common are autism, Asperger's, and PDD-NOS, and less common are Rett's disorder and childhood disintegrative disorder. So I'm going to talk a little bit more about autism today. This is a picture on this slide is of Leo Kanner. He was a child psychiatrist who came from Austria to US and opened the first child psychiatric unit in a medical hospital, Johns Hopkins, in 1930s. And he first time described the term autism. What he saw, he has seen 11 children who had difficulty in making relationships. They were by themselves, not interacting with people. They have delay in speech, and then they do a lot of things again and again. Initially, he made some assumptions which we nowadays know they are not true. He thought that these children with autism come from higher socioeconomic status, which is now we know is not true. Secondly, he thought that a lot of these kids have normal IQ. Now we know that's not true. And the third thing is he thought that a lot of these children does not have any medical problems, which we now know is not true. At the same time, Bleuler in 1950s was talking about schizophrenia, and he talked about 4 A's, and one of the A was autism. And so Kenner reduced the essential symptoms to 2, self-isolation and preoccupation with sameness. The definition we use nowadays was first given by Michael Rutter in 1968, who's a big name in child psychiatry, and he talked about 4 essential features, including lack of social interest, impaired language, bizarre motor behavior, and early onset before age 3. When we go to DSMs, which is more used in USA as compared to ICD-10, which is used in Europe and Asia. So in DSM-1, which came in 1960, and DSM-2 in 1967, there was no term of autism mentioned. First time autism was mentioned in DSM was in DSM-3 in 1980s. And the way we describe 5 categories which I just mentioned was first mentioned in DSM-4 in 1994. We talk a lot about autism and the prevalence, like why we see more and more children with autism. When DSM-4 came, TR in 2000, the prevalence was mentioned 2 to 5 per 10,000. Gilbert and Wing reviewed all the English literature between 1966 and 1997, and they give the prevalence of 5 to 10 per 10,000. CDC, which is Center for Disease Control in US, have 14 sites across the country, and the numbers you see more recently are coming from CDC. A few years back it was 1 in 166, then 1 in 110. The most recent number was mentioned is 1 in 88. The ratio of boys to girls is 3 to 4 to 1 girl. But when autism is in girls, it's much more severe. Girls might have more cognitive problems, seizure disorders. In children who have intellectual disabilities, there is a high rate of autistic features from about 9 to 12%. When it starts, in most cases, at least in US, and I'm involved with a lot of families in Pakistan, more than 50% of the parents are worried in first years of their life. And about 90% of cases, parents are worried by age 2. Common presenting problems include child might have speech delays, worry that child may be deaf, have difficulties with social interactions. I'm not going to go probably the whole DSM-4 criteria. You have books to read that too. But as you know, we look at 3 main criteria. One is for social interactions, and then communication, and third is behavior. In social interaction, we looked at child if they have impairment in nonverbal behaviors, like having a poor eye contact, they have difficulties in forming peer relationships, they feel comfortable by themselves. For example, if the child is coming from a school, they usually don't share with their parents what they have done or lack of showing. They don't point towards objects like with the finger, lack of social or emotional reciprocity, that mostly it's child side all the time and they can't see what other person is saying. Then is the communication. A lot of folks confuse communication with language. Language is part of communication, but not the whole communication. About 50% might have total or delayed language, but a lot of these children have language and they still can meet criteria for autism. They have difficulties in initiating or sustaining conversation. They repeat same things again and again, and then they have difficulties in imaginative plays, like for example playing with toys, police and thief, doctor or a patient relationship, and then there are difficulties with behaviors that they repeat things again and again, that things need to be in a particular pattern, or they are inflexible with their routines. They do hand flapping, moving in circles, preoccupation with parts of objects. In autism, about 70% have mental retardation and about 45% have severe mental retardation. About 10 to 35% have risk of seizures, usually in early childhood or adolescent years. Very high number are sensitive to light, sounds, or touch. About 60% have attention difficulties. About 50% have hyperactivity issues. High number, about 25 to 45%, have sleep difficulties, which can play a big part in how these children present. And then they have certain food preferences, like preferring certain kind of foods. There was a paper written which has done meta-analysis of 9 studies showing rate of temper tantrums in these children, 76%, about 60% have aggression, about 14% have stereotypy, means repeating things again and again, or adherent to specific patterns. About 11% have self-injury, like head banging. A lot of you folks, you have seen Rain Man. Some of these children or adolescents or adults have special talents or strengths. This is a drawing made by a 3.5-year-old girl, Nadia, of a horse. Usually it's much later in developmentally that they can make these kind of drawings. Same girl at age 5. And the beauty of this is that this girl has never seen a horse. Basically, she has seen horses in the storybooks. These are drawings by Stephen Wiltshire. He's a very well-known artist who made this drawing of St. Paul Cathedral when he was in his 13th year age. This is the same person. He drew Eiffel Tower. Now, interestingly, this gentleman is in his 30s, and he goes around different cities like Hong Kong or New York or Tokyo, and he goes on a helicopter and over the cities for about 2 hours, and then he goes to his studio and he can draw the whole downtown or whole main city in about a few days without seeing the city again. So, which is a remarkable talent. Going to the second category, Asperger's disorder. Hans Asperger was a pediatrician in Vienna. He first time described Asperger's disorder. He has seen few males who have marked social problems. Difference from autism is that these kids have marked social problems and they do things again and again, but they have good cognitive skills and good language skills. Usually fathers might have autism. Hans Asperger used to call these children little professors, and actually one of the child who he saw, and one child you can see standing with him on a picture, later on became professor of anatomy. It's much more common in boys, lack of friends even though interested in others. So that's a difference from autism, that in autism, children are not interested in others. In this case, children are interested in others, but because of lack of their social skills, they have a hard time in making friends. Good verbal abilities, but they repeat same things again and again. If you do a psychological testing, they have a verbal IQ, which is more than performance IQ, which is the other way around in autism. And difficulties are usually not recognized in early age. Diagnosis made around 11 or 12 years of age, at least in USA. Then comes the Rett's disorder, which will go out of DSM-5 since there's a particular gene called MECP2 has been identified in about 80% of these cases. It was first described by Rett in 1966 in German literature. Usually it's in girls. First few months, normal development, and then there is head growth deceleration After 5 months, loss of hand movements, autism-like features. They might have ataxia, scoliosis, breathing dysfunction. Then the fourth category is childhood disintegrative disorder, which we see much rarely. In these children, usually they have normal development for first 2 years of life, and then they have loss of language, social skill, bowel or bladder control, play or motor skills. At least 2 of these 5 need to be present to make the diagnosis. And seizures are much common in this class, much poor prognosis. When the child doesn't meet the criteria for autism or other categories, we call it pervasive developmental disorder NOS, probably at least 30 to 40% more common than autism. As I was saying before, nowadays we know that very high rate of medical comorbidities, about 10 to 15%. Fragile X syndrome is the most common cause for mental retardation in males, and they have about 15 to 25% autistic features. Tuberous sclerosis is another autosomal dominant condition in which a child might have seizures, tumor, in which about 20 to 25% have autism-like features. Neurofibromatosis have a high rate of autism-like features, and then Down syndrome, about 11% have autistic features. Other things to consider: if children have deafness or blindness, about 6% might have autism-like features. A lot of genetic factors or genes have been implicated with autism. Some genes like 2q33, CQ3133, 13q, or 15q have been implicated. Very high rate in identical twins, especially monozygotic twins, about 90%, dizygotic twins, about 60%, very high rate in siblings, about 2 to 7%. So if somebody has a child with autism, there's a risk of 2 to 7% that the parents might have a second child with autism. And if the other siblings might not have autism, they might have other associated problems like cognitive delays or speech difficulties or learning disabilities. Then there are some other environmental factors to consider. There was in the past a lot mentioned, because the article came in New England Journal of Medicine, that vaccines, MMR vaccine, might be cause for autism. Actually, that article has been rejected from New England Journal of Medicine. We know now that vaccines are not cause of autism. It was also said that mercury might be reason for it, which is part of vaccine of MMR, but now we know it has been removed, but still autism on a rise. Then there was some studies showing some food allergies might be reason for this, like gluten or casein, but there is no hardcore evidence for that. And a lot of these children have high rate of gastrointestinal abnormalities. So how we do assessment of autism? First of all, it's important that it's interdisciplinary approach, like a child psychiatrist or a psychiatrist or a pediatrician is involved, a psychologist is involved, occupational therapist is involved in USA. Speech pathologist is probably the most important person, because a lot of these children have speech difficulties. It's important that we ask input regarding the child from a lot of different resources and settings, like how this child is doing in school, how this child do with play. Family input is extremely important. Sometimes we ask only about symptoms. I think in child psychiatry it's extremely important that we always ask how the child's condition impacts the family's functioning. So for example, a lot of these families can't go to functions or anywhere because a lot of these children have behavioral difficulties. Then of course in Pakistan there's a lot of social stigma, so you don't take these children to any family gatherings. A lot of times, for example in USA or even in Pakistan, hair cutting can be a huge issue. Like these children have difficulties with hair cutting, or if you're going for shopping to buy shoes or clothes, that can be a huge problem. So what kind of things we think about when we're doing an assessment for autism or autism spectrum disorder? First of all is how these children relate with other children or adults, but especially children. Whether they have difficulties in looking towards the child, usually how these children do when they are with other kids, or they prefer playing by themselves. How these kids do when they come back from school or they're doing other stuff. Can they point towards other things? And can they do reciprocity, like for example, if the mom or father is saying something, can these children relate to that? Or is usually they can't see what other person is saying and they just give their background or history. Then is how these children's language or communication. A lot of these children have delay in language. Recently, American Academy of Pediatrics came up with certain criteria which is extremely important, especially for our pediatrician friends, that if a child is not babbling by 12 months or not making any gestures by 12 months, or unable to say a single word by 16 months, or unable to say 2 words together by 24 months, or any loss of previously acquired language, that these children should be assessed much more thoroughly for autism or other language-related disorders. Then third is how these children do with stereotypies. For example, do these children like to have things placed in a particular way? A lot of these children like their shoes to be placed in a particular way, or clothes should be hanging in a particular way. They are fixated with certain characters or cartoons. If you change their routine, like when they wake up, what kind of things they do, if you change their routine, that can pose serious difficulties. And a lot of these issues need to be present before age 3. Then why these children come to us, there are some other reasons at least why they come to us in the United States. One is very high rate of aggression, like are they aggressive physically, verbally, or throwing property, or doing those kind of things. Self-injury, are these kids doing headbanging, injuring themselves by nails, or those kind of things. Hyperactivity, are these kids hyper, very high rate of hyperactivity, are they on the go, climbing, jumping around, hard to sit still in the seat. Difficulty in paying attention, sleep difficulties, do these kids have difficulty in going to sleep when we're doing an assessment, or staying asleep? Because a lot of the children, not just in autism, if they have sleep difficulties, that can cause a lot of things like aggression or those kind of things. It's important that we ask pregnancy and neonatal history, any problems during pregnancy or during delivery, any trauma, developmentally, what age they started sitting, standing, motor milestones, language milestones, medical history, do these children have any other medical problems, especially gastrointestinal problems or seizures, as I mentioned before. How the families are doing, what kind of setting they are, for example, living in, how many rooms in the house, because it depends on what kind of environment is around them. How they're doing in school, are they in a regular class, specialized class, how many children in the class, how they relate with other kids, intervention history, what kind of things have been done in the past. Especially, for example, if they have received any speech therapy, occupational therapy, if they have received any medications, and then observation of a child. Although when we observe a child in office, that's not going to be the whole picture because the child is with adults. The most important is how the child do with other children. Then it's important to do a hearing and visual exam, the child if they have any deafness or blindness. Good neurological exam if they have any soft signs. As we say, Fragile X syndrome might be more common, so chromosomal studies sometimes we do over here. Psychological assessments, there are some scales we use for diagnosing or help to make a diagnosis of autism. Speech and language assessment probably is the most important assessment after making the diagnosis, and then assessment for occupational therapy and physical therapy to look at if they have any sensory issues or motor, gross motor or fine motor issues. These are the different scales we use to help making the diagnosis of autism. Childhood Autism Rating Scale. It was developed by Teach Model in North Carolina. Second is Autism Behavior Checklist, which is sometimes used by teachers in US. The two most gold standards are ADI, Autism Diagnostic Interview, and Autism Diagnostic Observation Schedule. Mostly in US, they are done together, which can help with the diagnosis, but it requires specialized training. And then Vineland Adaptive Behavior Scale. I know a couple of centers in Pakistan are doing this. It helps in measuring how these children do with day-to-day skills, social skills, communication skills, maladaptive behaviors, or motor milestones. And then IQ testing. Sometimes we use a test over here called lighter test, especially if the child is nonverbal. In younger kids, it's very hard to do IQ testing, so not recommended. So how we think about treatment of autism? Autism treatment is multimodal, and we have to look child and family in the center. They are the cornerstone of the whole treatment, and everything is around the child and family. In my mind, when I see a child, if I see one child, I see just one child. It doesn't mean that I know every child who have autism, because every child is very different. In my mind, families are the expert of their children and should rely heavily on family input, to make the diagnosis and to devise the treatments. So first of all, I will start with behavioral interventions. Just to mention a little bit more about behavioral intervention, actually that's a separate topic, so I'm going to mention just briefly about it. We use a lot of ABA nowadays over here, applied behavior analysis, which can help with if a child has some behavioral issues, that what are the triggers for those behaviors, what help and what doesn't help. Then speech therapy, as I mentioned before. If a child has language delays or severe speech issues, it's extremely important that they get speech therapy. The speech therapy given between age 3 and 5 can make the biggest difference for prognosis later on. Third comes the environment, like what kind of environment these children live in and how that impacts. For example, if there is a lot of chaos at home or things not changing on a regular basis, that might impact how these children live. Other things sometimes we use for environment, for example, we use a lot of pictures to help with the daily routine. Social skills, how we help these children, for example, to be good with the peers. So how we give them opportunity to play with other children, how we give them opportunity to interact with other children. There are some simple terms, like for example in USA we use like simple social skills terms like how you say please or how you say thank you, how we teach these children how to read other people's emotions like sadness or happiness, showing them some pictures. Then comes the education. I will talk a little bit more. Every child is unique regarding education, so it's hard to say that if one educational intervention helps one child, that it might help the other child. It is different from a child to child. There are studies done showing that a lot of these children have sensory issues. For example, these children don't like cloth tags on their back or might be sensitive to touch. We use sensory integration therapy, which is part of occupational therapy, which can be very helpful for some of these children with autism. And then medications or pharmacotherapy. That's we use as a last resort, not as a first option, but as a last option after we have tried everything else. Then we go to the medications. And also it's important to think about that how old the child is, because it's not the same dosages what we use in adults. It's much lower dosages what we use in children. Early intervention is extremely important. In USA at least, we have early intervention programs which sometimes now even start between age 1 and 2 years and can make a huge difference. It needs to be planned and intensive. Sometimes it is like 25 to 30 hours a week. I know that can be really hard to provide in Pakistan, but at least if we are thinking about intervention in Pakistan, the speech and occupational therapy are probably the most important one. And that it's an interdisciplinary approach. So it's not just a physician who provide the total care for the child, but it's a whole team which work with the child and the family. And then how we teach skills to these children, which are individualized based. And then of course child and family engagement is central. So when we have a child in a school, we evaluate a curriculum that what will help them in learning positively social skills. If they are older, 16, 17, over here we try at least adolescents to be functional or adults to be functional. I hope we will reach someday in Pakistan that some of these adults who might not be doing any job, that they can do some simple things. How we emphasize the strengths. So a lot of these children have strengths with music or computer. So sometimes we think too much about the weaknesses or symptoms of a child. I think it's even more important to look at the strengths of these children and the families. How we provide a mentorship. So for example, in Pakistan, the elder brothers or sisters can play a big part in helping these children. How we motivate these children, how we organize their schedules. So there needs to be, a lot of these children are nonverbal. Sometimes having pictures, for example, brushing the teeth, having breakfast, having lunch, doing homework, having those in pictures and timings in charts in their room can make a big initiative, big difference. Or some children, small individualized program can make a big difference. It's extremely important that they have a structure. So, for example, the routine shouldn't be changing from day to day. It should be the same routine over the days. And sometimes overstimulation can cause a lot of problems. So, be flexible. So look at these children, that how we can be flexible in accommodating these children in school or other environment. Just I'm going to talk very briefly about the medications or pharmacotherapy, and especially just two medications which have been FDA approved. So I'm going to just touch very briefly. I'm not going to go whole a lot about pharmacotherapy. As we know, so I'm looking at, if you're looking at the slide, it has 4 circles. One is communication, then is social interaction. Those are the 2 core features of autism. Medications don't improve those features. The other 2, repetitive behaviors, like doing things repeatedly again and again, or obsessive or compulsive, it can help with that. Or associated symptoms. Associated symptoms mean aggression, self-injury, hyperactivity, inattention problems, or if there is comorbidity with other psychiatric diagnosis, for example, depression. Very high rate of these children have anxiety issues. It can help with those kind of things. And what are the different medications used for these symptoms? Stimulants, I know stimulants probably are not available in Pakistan, methylphenidate or amphetamine preparations, but recently I believe amoxicillin came in the market in Pakistan, which we use for inattention, hyperactivity or impulsivity. It's important to know that, for example, if somebody has ADHD, we give stimulants in those situations too. Response rate in ADHD with stimulants is 70 to 90%. In children with autism, if they have hyperactivity or impulsivity or inattention, the response rate is about 50%. So I don't think both come in a same way how the children will react to these medications. And these children are much more sensitive to stimulants, so there is high rate of aggression or worsening anxiety if we give a higher dose or we don't titrate it properly. Second category is to think about SSRI'S like fluoxetine or fluvoxamine or citalopram or escitalopram can be used for repetitive behaviors and anxiety and depression. The studies done regarding SSRI'S, there is a positive study for fluvoxamine for repetitive behaviors in this population. There is positive study for fluoxetine in this population. And recently, one double-blind study done with citalopram with 150 children for repetitive behaviors, but it was a negative study, and citalopram was not found to be helpful in these children with repetitive behaviors. Atypical neuroleptics like risperidone or aripiprazole are FDA approved, so I'm going to talk only about those two in a little bit more detail, but there are other atypical neuroleptics like olanzapine or quetiapine are also used for some of these symptoms like aggression, irritability, temper tantrum, self-injury, and mood stabilizers. If somebody has mood instability, irritability, or especially seizures, then some of the mood stabilizers can be very helpful. There is a positive study, at least with valproic acid, for children with autism. So just going to go over the two medications which have been FDA approved, and then we can stop for questions and answers. Some of you might have heard RUPP network, Research Units for Pediatric Psychopharmacology. It includes a few institutions like NIMH, Johns Hopkins, Yale, UCLA, Ohio State University, and Indiana University. So they did this study which led to approval of risperidone for autism. There are a couple of things interesting about this study. One interesting thing was that it was sponsored by NIMH, so it was not sponsored by that drug company. And secondly, this was the first time the medication is approved by FDA in US for associated symptoms, not for autism itself. Associated symptoms mean irritability. So what they did in this study, there were 101 children, 82 boys and 19 girls. Mean age was 8.8 years. Range was 5 to 17 years. It was 8-week double-blind study. It was a randomized study. Mean dose in this study was 1.8 milligrams per day of risperidone. And with the risperidone, 69% improved versus placebo 12% improvement. There was improvement in self-injury, aggression, irritability, stereotypy, and means repetitive behaviors, and hyperactivity. There was weight gain, which of course we know as one of the side effects of risperidone, 2.7 plus minus 2.9 kg, and with placebo it was much less. Other adverse effects included increased appetite, fatigue problems, drowsiness, and drooling. No real extrapyramidal side effects were noticed. This study was published in New England Journal of Medicine. These were the scales used to measure the success. CGI, Clinical Global Impression Scale, 75% improvement with risperidone versus 11% with placebo. And then these are bar graphs showing especially improvement, statistically significant improvement with hyperactivity. Then the second phase started of this study, 16-week extension open label studies. 63 children entered this phase, 49 boys, 14 girls. Mean risperidone dose was 2.08 milligrams per day. 51 children completed the 16-week trial. 82% were responders on Clinical Global Impression Scale. And most adverse effects in this extension was congestion, nasal congestion, increased appetite, and coughing. And then the third phase of this study was discontinuation phase of risperidone trial. 36 children entered this phase. It was 8 weeks in duration, and children were randomized to ongoing risperidone versus gradual placebo substitution. Dose was reduced by 25% per week. In placebo, children who were converted to placebo, there was higher relapse rate, 62% versus risperidone, 12%. So eventually, this discontinuation trial was stopped. There are numerous other open-label and controlled studies showing effectiveness of risperidone in children with autism who have irritability or aggression. When we prescribe risperidone, it's important that dose is very different as compared to adults, or if we use it for psychosis or bipolar illness. In children who are less than 20 kg, the starting dose is 0.25 milligram per day, and you increase the dose after 4 days to 0.5 milligram per day, and then you stop, and then you look at how that child might respond to that dose. And if you have to make an increment, it has to be 0.25 milligram if the child is less than 20 kg, and usually the effective dose is 1 milligram. In the children who are more than 20 kilogram, the starting dose is 0.5 milligram, and then you can increase it to 1 milligram after 4 days per day, and then you stop, and then you look for improvement over 2 weeks. Increments shouldn't be made more than 0.5 milligram. Usual effective dose in these children is 2 milligram. 1 to 2 milligram is a good dose for children who have autism with irritability or aggression. Aripiprazole is the second medication which has been approved for irritability associated with autism. How it got approved? This study was sponsored by a drug company, and it was published in Journal of American Academy of Child and Adolescent Psychiatry in 2009. It was a double-blind placebo-controlled study over 8 weeks. 218 children and adolescents entered this study, aged 6 to 17 years, and then they were divided into 4 groups: placebo, 5 milligram of aripiprazole, 10 milligram of aripiprazole, and 15 milligram of aripiprazole. Starting dose was 2 milligram per day on the week 1, and then it was increased incrementally. Much higher rate on Aberrant Behavior Checklist for irritability and CGI, Clinical Global Impression Scale, with all 3 dosages. Adverse effects were sedation, drooling, and tremor. Weight gain with aripiprazole was 1.3 to 1.5 kilogram versus placebo 0.3 kilogram. So how we predict factors for outcome with children and adolescents with autism? First of all, as I mentioned before, presence of communicative speech as it is used in social interaction by age 5 can predict the positive outcome later on. If a child has a non-verbal IQ in the normal range, that can predict positive outcome. If a child has early intervention, that can predict a positive outcome. If child has seizures or a lower IQ, that can predict a negative outcome. So regarding medications, few things always to remember, just to summarize, especially about medication, that there are very few control studies. Medication is not the answer for everything. If a child, for example, have behavioral problems, we need to think about medical reasons for behavioral problems first if it is coming out of nowhere. And there are few medical conditions I always think about if a child or adolescent is developing a new onset of aggression or self-injury, that either if this child has constipation, if this child is in pain and can't communicate, or the third thing is if the child has infection. Always incorporate behavioral approaches with medication. Always start slow and titrate slow. So always start with a lower dose and slowly increase it. Don't start with a high dose, otherwise these children can't tolerate these medications. They are much more sensitive to side effects, so always think about that. Alliance with the families. How we think about a family as an expert and provide them support, like sport groups, and I know there are some sport groups around the country in Pakistan, in Karachi, Lahore, Quetta, Rawalpindi. A lot of cities have family sport groups for children, for parents who have children with autism. and then impact on child and family, how it impacts their lives. Just to finish my presentation, this is the Solnet Center, South Campus. This is the hospital where I work. We are one of the largest child psychiatric facility in the country, in US. We have 120 child and adolescent beds and about 12 units. And we have all the diagnoses you can think of. We have about 12 child psychiatrists who are board certified diplomats and 7 fellows with Yale Child Study Center and University of Connecticut. So training is a big piece over here. Every unit have a psychologist, social worker, nurses who work very closely with these children. And I know King Edward is online. I just want to share, probably you already know, Dr. Nazish and her team has developed a first inpatient child unit in Pakistan, which is a 6-bed unit at King Edward Medical University, which I'm very happy to know and see the growth over there. And I know all the other centers are doing a lot of work regarding psychiatry and child psychiatry. So thank you so much. So I'm ready for questions. Daniel, can you help with the question section, please?
Yes, sure. Yes, questions, please. I have unmuted you all, so you can ask questions.
Daniel, can I see the screen, the centers where they are?
Yeah, Kay was sharing their webcam. Let me check.
Webcam.
I can't see any centers on my screen.
So, you can use your mic, please.
Hello, Daniel, can you hear us?
Yeah, we can hear you.
Okay, sir. It was a very excellent presentation by today's speaker. So we are faculty from Department of Psychiatry, Department of Pediatrics, and with me Professor Raza Rahman, which is head of department in the Department of Psychiatry, Civil Hospital Karachi.
Wonderful.
And
wonderful.
And Dr. Saab will ask inshallah a question from you.
Sure.
This was a very nice presentation. I would like to bring one thing into light, that Dow University of Health Sciences is also in process of developing child psychiatry unit. Here Dr. Aisha Sarwat, basically she is collaborating with Nazish Imran, and they are developing.
Alhamdulillah, that's a great news.
Yes. And she's going to, tell something about that, what she has done to develop.
Sure. That's great. I'm so happy to hear that, because I know child psychiatry is still developing in Pakistan, so we are trying from here whatever we can do for folks in Pakistan.
So I'm Dr. Aisha Sarwat. I'm assistant professor in psychiatry. Walaikum assalam. How are you?
Good, thank you. How about you?
Fine, thank you. So it was a very comprehensive talk about autism, because it is such a large thing to talk about, has so many domains to talk about, but you made it so simple and very comprehensive. I think most of the people around here has followed it. A few things I just wanted to, a few questions, and I would also like to then tell you what we are doing. I read about something about AQ. There is something like IQ, there is something as EQ, and what is about AQ? Do you know something about that?
No,
Autism?
I'm not aware of anything about AQ. AQ, what it stands for?
It stands for Autism Quotient.
Autism Quotient. No, we usually don't use that over here.
Okay, so this is something which has been introduced by the Cambridge University.
So it must be from UK.
Yeah, UK. And it is a self-assessment questionnaire, and it grades the person. The person can do the yes and no answer, disagree or agree questions, and then it is developed for the children from 4 years onwards also, and it has an adolescence type of EQ also. So this was something I wanted to add, that this is something new which is going on, and it has been introduced from 2001 onwards.
Wonderful. That's great.
And it has been is done by Cohen. I don't remember his name properly, but I think it's Cohen Barron or so. He's a psychologist, a professional psychologist.
I know. Is it translated into Urdu or?
No, it's not. But it is something which we can think about, because when we go for EQ, IQ, and this is something new. AQ is something which an adult can also do, because many of the adults might be suffering from autism at times.
Doctor, what you're using to measure like day-to-day living skills or community? Like, for example, I can't remember. There's a scale developed by UK too. I know I gave Dr. Nazish and Dr. Friedman Haas Wineland, which was developed at Yale. I gave that, so I know especially Dr. Nazish and probably Dr. Fried's department is using that too, which is not just for autism. For children who have cognitive limitation or learning disabilities, you can see how they're functioning. And might be after you finish, Dr. Nazish can share, if she's online at the KE side, what she's doing with that Wineland scale.
Yes, Wineland social maturity scale, but much people are doing here, and in our department we don't have that, but we will definitely ask Nazish to share it with us. And one thing I wanted to ask is something about mind theory, the theory of mind. Is this something you would like to elaborate about in autism?
I'm not much familiar with that.
Okay. And another question is regarding the pharmacotherapy, that the children suffering from autism, they might be having hyperactivity, and along with that they would have aggression and all these tantrums.
Right.
So would you elaborate that the combination of pharmacotherapy can be used in these children?
Usually, if, for example, if somebody has aggression, usually aggression is the main reason the children come to us. Hyperactivity and impulsivity is not the main reason, but sometimes they come. We always start with, if somebody has severe aggression, might start with alpha-adrenergic, which is much safer, like clonidine or 10x, which I'm not sure available in Pakistan for this purpose, but risperidone in a small dose or aripiprazole in a small dose can be very helpful. And then you see if it will help with hyperactivity and attention problems too, because as you know, a lot of these children can't sit still. We have used, after doing all the behavioral intervention and atypicals for aggression, then I might go and add something for hyperactivity and impulsivity and attention span problem, but not to start with. I always start with more with aggression or self-injury.
Okay, because this has to be cleared, because many of the postgraduate students are sitting here, they should not combine the different drugs and keep the pharmacotherapy very simple.
Medication is the last resort. Usually when I show the circle, medication is the last thing on my mind. And I know when the children come to you, they are probably seeing this as a last resort to either they are aggressive. So we might start with. Other thing is, it's also important to know what's the reason for aggression. For example, some of these children have very high level of anxiety, which driving children aggressive. Some of these children can't communicate, and they get frustrated, they become aggressive. Some of these children might be in pain or constipation or those kind of. So it's important to first know what is the reason for aggression. And if you have ruled out every single thing, then I might go to atypical neuroleptic for this, but in a very, very small dose.
So regarding what we have done for the last, I have joined this department for last 1 year, and from there onward I have started a child psychiatry OPD once in a week in the psychiatry department, and we are catering all type of children, especially mental retardation, epilepsy, and all type of child psychiatric problems. And we have just started the services, and we are in the phase of developing the School of Developmental Pediatrics, which is with the collaboration of the pediatric department, the rehab center. We have a proper rehab unit in Dow University, and we are collaborating with them, also having a close liaison with them, so that it is a multidisciplinary type of because of the reasons that everybody has to put something in it. When the child psychiatry is not that much, we can say we are not very progressive, or we don't have a child psychiatric studies, or what we say post-graduation in Pakistan.
Sure. No, I think a couple of things. One is it's great what you're doing with OPD. Second is I think pediatric schools can play a huge part. I think school is probably the most important thing. Third thing is I had some conversation with Dr. Nazish and Dr. Friedman Haas, and because about possibility of starting FCPS in child psychiatry. So folks who have done 4 years of training to do 2 years of extra training with FCPS in child psychiatry. It's very preliminary. I don't know if Friedman Haas is online on the Rawalpindi side or not, but I'm talking with these and I'm giving them curriculum what we use in US for child psychiatry training, because over here training is 2-year fellowship. So I'm giving the same curriculum to people in Pakistan to how, if we can develop FCPS in child psychiatry.
Hello. Hello.
Dr. Waqar, I would like to, bring in your notice that I don't know whether Fariz bin Haas is doing that or not, but Dow University of Health Science is very much interested in developing capacity building and training. So Dow University is basically developing its own programs. We are in process of developing diploma course and higher diploma courses in psychiatry, but we would appreciate if you are going to collaborate with the Dow University of Health Sciences and help them in developing any course on child psychiatry. We will definitely appreciate, because Vice Chancellor is very much enthusiastic about that, and he is particularly more interested, and we would like that if you can guide us and help us in research field, in particularly in autism.
Inshallah, like I think I have to probably come to Karachi more often. I'm collaborating with Pindi, Lahore and Faisalabad, Punjab, 3 medical colleges since 2006. So I come every year and I visit at least 2 places. And Allah, Dr. Haroon ko Jannat Naseeb Kare, I was very close to him. So I was talking with him like 5-6 years before he died, unfortunately, at Fatima Jinnah too. So Aga Khan sirf mera chakkar laga, but I have not been to Karachi that often, but certainly I hope I can visit Karachi more often too.
You are welcome. You are welcome whenever you visit Pakistan. Do come to Dow University of Health Sciences and just inform us. And I would appreciate if I can get your email contact. So we are going to remain in contact with you whenever you come to the Pakistan. Then
Daniel, you are online?
Yes, I am online.
Might be the main people, contact people in all the centers who are joining might be good. A lot of them have my email already. Might be good to send my email to those folks.
I will for sure. I will send your contact information to all of them. Yes. Yes. And I think AE wants to participate now. They have questions. King Edward, please.
Assalamu alaikum. Can you hear me?
Hey, Dr. Najis. Assalamu alaikum. Nice to see you.
How are you? Nice to see you.
Good to see you. How are you doing?
I'm fine.
I'm waiting for the pictures of your inpatient unit.
Yeah, hopefully you'll get it next week following the inauguration.
When you're opening it?
On 12th, hopefully. That's the plan.
The 12th will be the inauguration?
Yeah, formal inauguration, yeah.
Congratulations,
okay.
that's wonderful.
First of all, I would like to congratulate on an excellent presentation, and I think it's been very helpful for our trainees and psychology trainees as well as speech therapy students who are present here as well. I would like to have your comments in particular that what is the current recommendations as well as the current practice regarding the casein-free, gluten-free diet used in children with autism spectrum. So I think that will be helpful. And regarding Vineland, would you mention? I think
how about I should answer the first question first?
Yeah. Okay. Okay, that's great.
So casein-free and gluten-free diet is used for a long time in America, and now I know, Dr. Nazish, you know, there are a lot of parents who are using it in Pakistan too, because they're following all this stuff, what is happening in USA. Casein means casein is a protein in the milk, and gluten-free diet. It's very hard to do. First of all, like you can't give ice cream and those kind of things to the kids. There was study done recently which showed that there is no real positive benefit of this diet. But 60% of the parents and families use this diet, gluten-free, casein-free diet, in children with autism in USA, and I know very high rate in Pakistan are trying to do that too. In my mind as a child psychiatrist, if I'm working with a family, if it's not causing harm, I don't tell them that I'm the specialist, you shouldn't do that or you shouldn't do that. I go with if it's not causing harm. If you want to try, that's fine. So in a clinical practice, I sometimes go with it if it's not causing harm, because there are a lot of things like, for example, some parents like giving vitamins, which is like not studied properly, so I don't say anything that you shouldn't use that. If family want to use it clinically in my practice, that's fine. There are certain techniques which can be harmful, like chelation. There was a death of a child over here in Pittsburgh with chelation, which can be harmful. Then there are sometimes some people use IM vitamin B12 injections. There's no study showing effectiveness of that, so I usually don't recommend that. And at the same time, as you know, parents are desperate. And I know in Pakistan, people from USA and around the world going there saying they can cure their children and charging parents thousands of dollars. And unfortunately, they rob the parents, but they are desperate, so people take advantage of a lot of folks in the country. So regarding casein-free, gluten-free, there is no scientific evidence. In person, I have seen a child or two which have benefited from it in my clinical experience, but it's very hard to do, but there is no scientific evidence to support this.
Yeah, thanks a lot. Regarding the Vineland Adaptive Behavior Scale you mentioned, and I think that I have personally found it a very helpful tool for children with learning disabilities, intellectual disability, as well as in children with autism spectrum, to get an idea of their level of functioning, and especially when we don't have the other IQs tests or tools available for nonverbal children.
Sure.
The only sort of few issues which perhaps hinders its practical use in day-to-day clinical practice in Pakistan, one is the parents, majority of the parents who present to us, they are illiterate, and it's quite sort of time-consuming to do it in a very busy outpatient setting. So it takes, suppose, 1 hour for one child to do it. So practically that sometimes is one of the main factors. It's not used very often. And to be honest, the resources as well to photocopy that for every child who's presenting to us on daily basis would be a problem as well. Instead, in clinical setting, day to day, we do use the Portage guide, which has got sort of similar. So it was the Portage guide, I think, which you were thinking about earlier, which we do use practically, and and that also gives a similar level of functioning to give us an idea of the strengths and difficulties of a child and what needs to be worked in the management plan.
Because I went to Amin Maktab, which is a school for special kids, and Punjab Medical College. They are using the Portage too. So most of the places, I believe, in Pakistan use Portage. You're right.
Okay, anyway, nice to hear from you. I think there might be some other questions from our side as well.
Nice to see you.
Assalamu alaikum, sir. I am Dr. Usman Hamdani from King Edward.
Assalamu alaikum.
Sir. Sir,
Usman, I remember you.
Thank you, sir. Sir, I was fascinated about this all presentation and autism specifically when we see these patients in terms of not only the patients but I was thinking about the etiopathogenesis about the disorder, and I did some literature review about it, and there are some fascinating theories about neuronal contacts, serotonin, GABA glutamate, and everything. And that is a worth area for research, I think, that's going on. Or I wanted to have an update of what is the most significant contribution, or which theory is contributing the most in the etiopathogenesis of the disorder.
I didn't went into the etiology of autism. There are like 5 different ways how you look at etiology. One is, for example, how the brain of these children might be different. So there are studies done showing smaller cerebellum in a lot of these children, and some studies showing smaller amygdala. Amygdala deals with emotions, smaller basal ganglia, reduced size of corpus callosum. So those are some of the anatomical things you might find on MRIs. There are studies done, like it's very hard to say that you can pinpoint there is one reason for this. You can't, it's very hard to do that. Right now I don't think nobody can say that this is the reason for autism or that's the reason for autism. There are studies done, as you know, high rate of serotonin, then there are studies showing high rate of opioid receptors, high rate of dopamine, catecholamines. So those are the different things, but there's no thing mentioned which can say that 100% this is the reason. Then there were infections mentioned, like toxoplasmosis or those kind of rubella during pregnancy. So those were mentioned in certain literature, but nobody can say that this is the definite reason. In Pakistan, clinically, when I think about when you're doing a clinical practice, the biggest challenge I think we deal with is that parents or mother feel that they have done something wrong during pregnancy which led to this. So the most important, like my mind, other than research, goes towards how you reassure the parents to start with that what a wonderful parents you are, that how you look at the strengths of the family before talking about the issues or problems of the kids, and that it's not anything they have done wrong, because guilty feeling in these families can kill them. So I think clinically it's important how you support the families and parents. But the research-wise, I was saying, so there are a lot of theories, not 100% completely. Nobody can say that there's one particular way why autism is caused. That answer that?
Yes, sir. Thank you for your answer, sir. One thing that I couldn't find an answer to was, for example, in childhood disintegrative disorder, there is a period of normal growth followed by regression.
You're right.
So, what explains this? I couldn't find an explanation for this. How could this happen? What could be the...
Nobody knows the reason. One thing is, like for example, even if children have autism, not just childhood disintegrative disorder, 1/3 usually grow normal for first 12 months of life, and then they might develop autism-like features. In childhood disintegrative disorder, nobody really knows the reason, but it's a little bit different because children have neuronal development, plus they have much higher rate of seizures as compared to with autism. And third thing, it's much rare, and the prognosis is much poor, but the cause nobody knows.
Thank you, sir. I was just in this dilemma sort of thing. Why this happens?
Sure.
Do we have more questions?
Can you hear us?
Yes, we can hear you.
Yes, I think thank you very much. Here in Dow University of Health Sciences, we have 3 institutes, and Dr. Ishaq from Dow International is here, and I would like that, Dr. Ishaq, your comment.
Thank you.
Thank you very much, Dr. Waqar, for such an excellent presentation, and I feel myself an unlucky one because I joined you later, but it was very nice to hear you, and it was, I think, very much, it has given us a very much update on what is going on in autism, and
I would appreciate if you could kindly drop in at Dr. Abdul Qadir Khan Institute of Behavioral Sciences, which is a very elite kind of institute in Karachi in its developing phase. And I'm working there, and we would like to welcome you too while you are in Karachi. Please keep in touch with us. Thank you very much, Dr. Waqar.
You're making me feel guilty. I have not done justice with Karachi. I have to make it up for that in the next couple of years.
Well, I hope that you will definitely be coming to Karachi now and will be helping us out of this.
Inshallah.
And with this, I thank you on behalf of Civil Hospital and Dow Medical College, on behalf of Dow International Medical College, and whole of Dow University. Thank you very much, Dr. Waqar, to be with us today.
Thank you so much. Daniel, is our MC online?
Yes, I am here. Yes, I think we don't have more questions. Yeah.
Okay.
So, thank you very much, everyone. Thank you, Dr. Waqar Azeem, and good night.
Okay. Good night, everyone. Nice to see you all.